Oh God, yes, he needs one.
No.
Hello.
Are we gonna be?
Yeah.
It's just, I don't think, it's just a Cfac.
Yeah. We just missed them. Not that way.
Thank you, Jerry.
How are you?
Good.
Good.
Morning, Rebecca.
You're welcome.
See ya.
Oh, hi.
How are you doing? I'm doing good. How about you? Great.
The top? Yeah.
Oh, wow.
One of Good start. He's rude myself.
Okay, I'm gonna get our meeting started. I'd like to welcome everybody to the Western Highlands Network Community and Family Advisory Committee. We have a lot of guests tonight, so I would like for us to go around, introduce ourselves, and say what county we're from and the area that we represent. So if I can start down with Michelle.
I'm Michelle McCullough from Buncombe County, and I represent mental health and IDD. Donna Lyerly, Henderson County, represent mental health.
Marsha Riley, Western Highlands Network.
Leslie Huntley, Polk County, mental health.
Lisa Will, Henderson County Substance Abuse.
Jane Lindsay, Henderson County Substance Abuse.
Yeah, and I'm Nancy Baker, and
I'm Dave Richard from the Division of Mental Health, Developmental Disabilities, and Substance Abuse Services. Forever known tonight as the division, so I don't have to say it that way.
okay, there you go.
Sam Stephanie with Community and Consumer Relations.
And I'm from Rutherford County, and I represent IDD and MI.
And I'm Dreama Wilson. I'm from Buncombe County. I represent mental health and IDD. I'm Debbie Hammer from Rutherford County. I represent mental health.
My name is Ron Sheedy. I'm from Transylvania County, and I represent IDD.
Stacey Brown, I'm your consumer empowerment team.
I'm Bill Cook from Mitchell County, and I represent substance abuse.
I'm Dick Graham. I'm the Cfac liaison from Western Highlands Network.
And now I'd like to give our audience time to tell us who you are.
Thank you, Nancy. I'm Jenny Pugh, and I work with Smoky Mountain Center, and I'm Senior Director for Community Collaboration. The person that you have been working with from Smoky Mountain, Brian Shuping, is our Cfac liaison. He's on vacation this week, so I'm here to represent Brian. Thank you for having me.
And I'm Vince Newton, and I work for the division, and it's great to be back and see a lot of familiar faces again, and to see you guys are still dedicated and committed to all of the consumers and all of the individuals that we are all concerned with.
Janet Price Farrell, Executive Director for Parent Advocacy, Parent Resource Center here in Asheville, Developmental Disabilities.
I'm Roxanne Colwell with Family Support Network of Western North Carolina.
I'm Terry Aker. I'm a training education outreach coordinator for the Family Support Network of Western. And a parent.
We're introducing ourselves.
I'm Bill Kinchner from Mounting, Western Carolina. Thank you.
I'm Tommy Thompson, my guest, and I'm from Greensboro, North Carolina.
I'm Suzanne Thompson. I am the team leader for the Consumer Empowerment Team at the division. Christina Carter, Chief Operating Officer for Smoky Mountain Center in Western Highlands.
And I'm Brian Ingram, happy to be the CEO for Smoky and Western.
I'm Pat McGinnis. I belong to Smoky Cfac. I'm one of 3 co-chairs for Smoky Cfac. I'm from the Central Region.
have all of you here. We're going to kind of run our meeting a little bit different tonight. We are going to do some quick business to start with. Then we're going to take about a 5-minute break, let people get some food, coffee, drinks, whatever, get them, come back and sit down. Then I would like to ask Mr. Richards to introduce himself, tell us a little bit about him, and then I'm going to open it up to our Cfac to go around the table and ask him some questions. And when we have completed our questions, then if there are questions from the audience that they would like to be able to ask, we want to give him that time to do that. We will follow this procedure up until about 20 after 7, unless we get done prior to that. And then we will go into our brainstorming because we have some work that we need to accomplish tonight. So we'll take the last 35-40 minutes of our meeting to get what we need to get done. I have asked that when we start the questions, we do not get on tangents. We stick to the point. We ask the questions. We try to get our answers. If Mr. Richards can't answer them, I'm going to have a list of questions he can take back with him, hopefully get the answers and get them back to us. So that's kind of the procedure we're going to follow tonight, to try to get in as much as we can, get as much accomplished as we can get tonight, and as much info as we can tonight. So if we could look at our agenda and look over it, see if there's any additions or corrections that we need to make to it.
I move that we approve the agenda.
A second.
Any discussion? All in favor?
Aye.
Thank you. Okay, if we could look over our minutes, and I think we all have a copy of them. Is there any corrections to the minutes? Do I have a motion that we accept our minutes?
Yes, you do.
Okay, do I have a second? Second. Any discussion? All in favor?
Aye.
Thank you. All right, that took care of the most important part of our business here that we needed to get done. And I'm going to give everybody a quick break. If you need to run to the restroom, please get food, drink. If we could all be back about 15 minutes after 6, that will give us about 7 or 8 minutes. Hopefully get food and come back, and then we'll turn it over to Mr. Richards. Okay, let's get back and get ready to start the meeting. Okay, I again would like to thank Mr. Richards for taking the time to come and visit our Cfac and answer, hopefully, a lot of our questions. And I'm going to turn it over to Mr. Richards, let him tell us a little bit And then I would like to start our questions with Leslie, and we'll go down the table.
Great, thank you, and thanks a lot for letting me come. One, it's a pleasure to be here, and let me tell you a little bit of why I'm here, and then if you indulge me for about 5 or 10 minutes about some of the things we're trying to achieve at the division, and then I am really looking forward to your questions, but as much as questions as input about how we as an organization, the state system, can work best to meet individuals' needs. First of all, I want to thank Brian and Christina and Jenny for their hospitality when I came early. I had a chance to meet with them, and I know they rearranged the schedule to do that, to talk about some things that can be helpful to us as we emerge going forward in our system. So that was also very helpful. I started this job about 7 weeks ago. And I was, prior to that, the executive director for the ARC of North Carolina, which provides some services in this community. So I'm familiar with Asheville, familiar with the system and how things have gone, and some of the things that haven't gone so well. So I have a little bit of knowledge about that. I was told several people I had a good job. I was very happy with the job I had. Had a real opportunity when some colleagues recommended to the secretary I'd be somebody to talk to about the job for the Division of Mental Health, Developmental, Disabilities, and Substance Abuse Services. And but I went in that meeting with the idea that it would be a great chance to meet the secretary, spend some time talking about what I believe, and really not thinking a lot would come out of it. And what I've told folks since then is that after an hour and a half, I came away as a true believer in what she was trying to achieve. And most importantly, because I knew her commitment to the folks that we care about and across the state was one that was real. It was absolutely unwavering in that effort. And 7 weeks onto the job, of course, you would expect me to say this, but I'm going to tell you the truth, is that nothing's changed. In fact, I feel stronger about that commitment to get things right. And so I want to talk to you a little bit about what I think that means in terms of from our division standpoint and what our system needs. It's no secret that we've gone through an awful lot of change, right, and awful lot of difficult change. It's also no secret that some of that has not went well. Some of it's been smooth, some of it not so smooth. But that change required all of us, you, the LME, MCOs, the state, everyone to kind of take a new look at how we did business. I believe that we sort of lost somewhere in this process, lost the goal. And that really was about people. And not everybody, but the system itself sort of lost sight of what we were trying to achieve. I was around long enough to be here for the first iteration of mental health reform, and I still recall that the fight there, and it seems like the argument's been since then, it's been about governance and how do we manage the system and organize it. And not a lot of time is spent talking about what does that mean and what we want to see for the people on the ground. And that includes providers and families and people with disabilities and other folks that use our system, and what that should look like for people. And my interest in doing this job was to sort of turn that conversation around and begin to really think about it from the sense of the ground up. What makes a difference for people? And I would talk a bit about the partnership in a minute that you've heard a lot about, but frankly, to me, that's, in the long run, that's the least, that's not the right way to say it, it's less important than figuring out what is it that we're missing in our system and trying to rethink that design in a way that will make a difference for you and the people that you represent. Part of the first week on the job, I had the opportunity, a lot of people said it wasn't an opportunity, but it was the opportunity to go to a regional Cfac meeting that had a lot of folks from around the state. I don't know if any of you guys were there, in Winston-Salem. And yes, you were there. And I went because the secretary was going to attend, but she had to stay back because of some legislative issues, along with the Medicaid director. And in very fairly, people at that meeting were disappointed that the secretary wasn't there. And frankly, probably disappointed with the answers that I could give, because I did plead 3 days on the job. I didn't have a lot of answers at that time. We have since sent the Cfacs a letter that I think outlined a lot of the answers to the questions that were raised at that point. But it was clear at that meeting that the idea of getting around to speak to families, consumers, people that use our system across North Carolina sooner rather than later was very important. And that's why I've sort of embarked in this effort to see each Cfac sometime. I thought we could do it in 2 months. I joke, y'all all meet on the same day, so it's almost impossible to do that. But hopefully within 3 months, by the end of October, we'll have a chance to have been to each one of the Cfacs, even the sort of regional sides of those who go forward, primarily to hear what you have to say. Tell you a little bit about what we're trying to do, but hear what you have to say, because that's how we'll build a system that works and that's sustainable. Is to listen to what people on the ground need and want, to try to create a system that responds to that. Most importantly, be honest about what we can and can't do, because there are some things that we will disagree on, and we'll just have to be honest about those and say, this is how we have to proceed. But that doesn't change the dialogue. It has to continue, and it has to continue in a way that is meaningful and makes a difference every time we have that conversation. A couple of directions that we want to head, and I say this and I say with all sincerity. I knew a lot about the IDD system coming in because that's what I spent my life on. I didn't know a lot about mental health and substance abuse. Learning rapidly on the mental health issues, substance abuse catching up pretty quickly. But it is not, in my mind, it is not okay to have a system that winds up having a lot of people show up in emergency departments that have mental illness rather than having the right treatment on the ground. We were talking about that earlier. What's the right mix of services to do that? It's just not okay to have that happen in our state. It's not okay to have a service system that doesn't meet people who have a substance abuse and want a substance abuse problem and want to address that immediately and not be available to do that. It's not okay to make that happen. It's not okay to have 9,000 people on a IDD waiting list across the state. It just isn't good enough to do that. I know the Secretary agrees with that we have to be better. I know that her leadership team believes that. And we have to do it in an environment, as you know, that isn't going to offer a lot more money to do these things. People ask me all the time, do we need more money? And my answer is, I don't think any of us can tell you that honestly at this point. It's easy to say, sure, you need more money. But the truth is that we have to get everything organized in the right way. We have to prove we can manage the money appropriately and deliver. And if we need more, I think the leaders of the state will find a way to make sure that happens. But until we can make that happen, until we can show people and understand that the trust they've put in us to manage the system is well placed, then we probably can't expect a lot more. Although I must say the General Assembly in this budget that's about to be passed has done a couple of things. This group home issue, they've put some more money out to deal with that, and they've added money for 3-way hospital beds, which I think is an important thing to do. So it's not without a movement. And a big thing is they put an awful lot of money into Medicaid, that's recurring money, to make sure that the holes that have been there that we started with are fixed. So there are signs that the General Assembly wants to make sure the system works well. Let me say a couple of words about the partnership because I know that's on people's minds, and then sort of open it up for questions. How's that? Many of you know back in January the governor announced that he wanted to have a new plan around Medicaid in February, and he called it the Partnership for a Healthy North Carolina. And the concept is that rather than doing a managed care carve out just for behavioral health and long-term supports that we have now, that all Medicaid funds, the 13-point-something billion dollars worth of Medicaid funding that this state used, would be within a managed care system. That would include physical health and behavioral health and long-term supports, and that system would be integrated. Obviously, it has met with an awful lot of controversy and people worried about what it looks like. The concept was there would be 3 big managed care organizations that all that money would go into. They wouldn't be regional. They would be statewide, and that people would have a choice in which one to be in. So the General Assembly has, in the latest version of the budget bill, which should pass and be signed by the governor hopefully end of this week, has put some parameters around that. And what they've said is that they want the department to come back with a plan for an 1115 waiver, which is what this would be under, present it to the General Assembly through a 5-person advisory committee that'll work with the department as we go forward. And at the end, when they start the session, the short session next year, then they'll make a decision on whether or not to go forward or not in the General Assembly. So there's a lot of work that will go on between now and then to have that conversation. What I've been suggesting to people, and will say to you, is that frankly, the outcome of what does it look like in terms of a 3 CCEs, a combination of LME, MCO, CCNC, some other things, that's going to get worked out over the next 6 to 7 months. I'm pretty confident that we will move toward an integrated system to where behavioral health and physical health will be all part of one system. And that's the ultimate goal. And that's the goal of that, meaning let's stop talking about people in silos and let's start thinking about people as a whole and figure out how to do that. Now, there are a lot of pilots. I know Christina was telling me earlier, there's a lot of good things going on in this area about integration and how that works. And so there are a lot of things we can learn and we can build in. What I'm hoping Cfac can do is to be a part of the conversation about what kind of outcomes are we looking for. We spend an awful lot of time measuring how much of something we do. We don't spend a lot of time measuring what are the outcomes we're trying to achieve with what we do. And you are the experts of what those outcomes are to be about. You're the folks that can talk best about what kind of outcomes you want for your family member, what kind of outcomes you want for the people that you advocate for, and engage us in that conversation. There are a lot of ways to do it. This is one, and that's the reason why I'm out doing this. Others are to send emails, write letters, call anytime. I'll leave a phone number and cards to do that. Come to Raleigh if you can to have a shot to talk to folks if you want to bring some people in to do that. We're hoping to set up a meeting with Cfac chairs to come in and have that conversation. We've been a little bit delayed because of the session of getting that done. But bring your ideas about how we should measure outcomes. What are the best things about the system that are working? What's not working? And let's together carve a path that the future is sustainable and makes sense as we go forward. Last thing I'll say is that one of the secretaries, the word we hear every week often in meetings is, does it pass the common sense test? I like that because I'm not those of you that know me know that I'm not an academic. I spent all my years kind of working in organizations. And I often think there are some incredibly brilliant people that have great ideas to do things, but sometimes we don't think about things with common sense. We do stuff that sounds great, but it doesn't work on the ground. I think people on the ground, you, the providers that work with you, the folks that work within the LME, MCO, can actually can come up with the best ideas, but you in particular can. I've been saying this to our staff in Raleigh, is that we have really talented and committed people at work, both in the Division of Mental Health, Developmental, Disabilities, and Substance Abuse. I got to just say division, and DMA and the department. But honestly, the innovation isn't going to come from there. We have a lot of good ideas, but innovation is going to come from the ground. Our job is to do a couple things, I think. One, to make sure that the money that the General Assembly chooses to appropriate for these services gets down to the end user, the consumers and families and providers that do their service with the least amount of administrative burden possible. We got to stop taking a bunch of money off the top before it gets to the ground. And secondly, to foster that innovation, to work with people to find things that are working great and spend our money on those things that we can either duplicate it, replicate it across the state, or when it doesn't make sense to replicate because it's a unique something to a community, that we know the difference, right? And we help people understand that. But help foster that innovation, bring it to the state, make sure we get the funding down to the level without as much, with the least amount of administration as possible. And the best way to do that is to listen to you guys about what are the best ideas. So that's why I'm out here, is to listen. I'll try to answer your questions the best I can. If I can't, I'll take them back. If I can't answer them then, we will. And we'll keep the dialogue open with what I hope we do. So that wasn't really a powerful speech or anything, but it seems like a much better thing to do in this group. How's that?
That sounds fine.
Okay.
Leslie?
Well, you've already answered my question.
Okay.
I was going to ask you what your experience was in mental health and substance abuse.
So let me add to that, because I wouldn't be happy with my answer yet. How's that? If I were you, right? What I do have a little bit of experience, because with the ARC we did provide services to people who had mental illness through guardianship and through housing. There's an awful lot of work on that. But what I do know are some of the most, I think, the people that do this the best around the state, and have spent the last 6 weeks, besides driving around to Cfacs, consulting with folks that are doing it on the ground. The providers that do the service, the ones that I think are best. Frankly, some people that I had no idea whether they're good or bad, but going out to see exactly what they're speaking of as they're doing this. So I am learning rapidly, and again, I will never claim to be an expert on mental health services. We have a lot of them in the division, but what I think I can do is organize with those ideas and the best ideas together to make sure that we're bringing them to bear. I have a commitment to the secretary that by August 15th, I'm going to have in her hands it won't be a plan. It's going to be action steps toward addressing some of the most critical issues around mental health. We'll get out to the community and make sure we're right, and we're going to test that. But we have a crisis. You know, the crisis that shows up in the paper every day is how many people show up in emergency departments. How many folks aren't getting the service they need on the ground. Now, we can debate the numbers, you know, and how many that really is, but we know it's too many. And we can't wait to have another big plan developed. We've got to start taking action now. And so we will, and you'll get a chance to see those steps as we go forward. But we're not going to wait for another year to begin that process. We're going to start now.
Nancy only lets us each have one question, so I has to go to the next person.
She's tough.
Yes, my name is Lisa. I'm from Henderson County, and thank you for coming to hear us and discuss these issues. I appreciate it. Recently in Henderson County, we've had a very successful effort in training law enforcement officials with the issue of crisis intervention training. What are these officers going to do when there are no bases, no facilities, with beds open, where they can place the individuals they're encountering?
It goes to the conversation I've been having with the secretary and people around the state. And this is, I want to test it on you. This is what I think, is that we've spent a lot of time thinking about crisis. We've not spent a lot of time thinking about what gets people to the crisis point. And I say that we don't have the array of service and supports that people need prior to that crisis event. Brian says we got to work downstream. I don't use that word that often, but I kind of like the way he says it, so I'll probably start using that more. Is that if we wait till somebody has to go to an emergency department or to a state hospital to really address the issues, we're too late, right? We got to start on the front end. Can't do that immediately. So we're going to work hard to create that service array, work with the LME MCOs to figure out how our state money can be used the best way to do that. And then we're going to try to use some of the tools we have at our disposal right now. One is that we have the advancing efforts around telemedicine that we think has got great opportunity if used properly. Two is we know we need more inpatient kinds of crisis. I'm getting a word that we use now. Help me.
Walk-in centers.
Thank you. Walk-in centers and that's not what I'm trying to talk about.
Remote crisis.
No, not remote crisis.
Facility-based crisis.
Facility-based crisis. Thank you.
Got it. Sounds like.
Sounds like. I know. I apologize. All of a sudden the words lost me. I've been talking about it so much in the past several weeks, but we have to figure out how to fund that in a way that we can have that in local communities to make that happen. Because, as you know, if there's no place to go, then that's people want an emergency department. So we have to have those less intensive services available in the community to do so. It's not going to happen overnight, but why I think we have to give the secretary something that says, here's our action steps. These are the things we're going to do. I can walk in my office, we have about 10 plans that have been on paper about how to address these issues that have been talked about for the past 10 years. There's really nothing new about this except for maybe telemedicine and doing that. We just have to implement and we have to execute as we go forward. We have to work with our LME MCO partners, not in a contractual way, but in a way that's partners that say, you know, this is one critical issue. How do we go about getting the services on the ground to make this happen? It's different in every community, but we have to do that. We have to execute, and we have to follow through. So that's what we're trying to achieve right now. I wish I could tell you that those officers and people that are trained by the first of the year, they'll have a place to do it. I can't tell you that. What I can say is that by the first of the year, I think we'll have a pathway to where people will believe that there's an opportunity in the future to make this happen.
I kind of a follow-up question.
Sure, give her a follow-up.
No, we'll come back around to you.
Okay.
I tried. That's why I was asking for a follow-up, really.
This is something that I brought to the Cfac committee before, and I talked with Christina Carter about it. So I'm going to bring it to the state level. I know that the state has got to have some kind of plan developed and implemented to ensure quality of care and continuity of care. And that would include a pool of staffing, backup staffing, properly trained staffing. We identified Western Highlands. I have to give them, applaud them for coming up with an unmet need, and it's still an unmet need, what they call extraordinary needs individuals. And what I want to know is what does anyone plan to do to get these extraordinary needs met for these individuals, because it can be met within the cost limit. I think it would start off with a set of standards for each provider agency. I think that a level 1 individual compared to a level 5 individual gets the same person to come in and work with them. And I'm hearing horror stories from the lowest needs individual to the highest needs individual. When Carol Steckel was at the Children's Center, the main thing that was identified was Medicaid problems with the need for properly good trained staff, adequate staff. Not put an ad in the paper, not take a body, not take it to that individual home, not say, okay, here's your person, you're good to go. All you hear the Qs in this area do is complain. I hired someone, I trained someone, they lasted a day, they lasted a week. I waited 18 months for backup staffing. I waited for a pool of staffing. I waited for properly trained staffing. It's not happening. And when I hear provider agencies tell me that it takes as much for administrative costs as it does to pay that direct care staff, you're never going to get quality staff unless you can offer them something. Even the staff at McDonald's gets a raise. They get some perks. The staffs in this program, the direct care staff, get nothing. They get nothing. And there is a need, and there is an extreme need for the extraordinary individuals, because they're harder to find. The individuals are harder to take care of. They have health-related tasks that need to be done. And I don't know how to get that across to anybody, so I'm putting it on you to try to get some answers to come up with how does the state do it, because personally I've been waiting 22 years for it. And it is a topic that we discuss, is inadequate staffing.
So there is no easy answer to that. There's no tomorrow answer to that. But there are several things that I think we have to begin to engage in. One, we have to rethink how, I know it's innovations, whatever you're talking about how we pay providers within the waiver structure. One of the great opportunities I think we'll have over time with managed care is to change the system from one that pays on cost reimbursement around 15-minute increments to one that sets up a payment structure that helps share risk with providers. that are high quality, and also share benefits with providers, and potentially share benefits with family members and individuals in doing this. The current system, and I feel comfortable talking about this, really rewards the more services you do rather than quality services, because organizations have to bill out in order to create a budget level that's sustainable. In the innovations waiver, as you know, most of the things that people do aren't changing every day, nor are they different from each hour of the day. Certainly broad-based service definitions that allow for much more flexible billing structures would work. That's one way. Number two is I think we have to really think a lot about how we're structuring the innovations waiver compared to how we pay for our high-cost services around the state, in addition to what's an innovations waiver. You know that we're going to assist score and ultimately some sort of a matrix to determine level of need and how much is getting funded. But we leave out the other residential service, the highest cost residential service from that effort, the ICF and the state facilities that are very high cost. Now, I don't think we should be robbing from one to pay the other, but we have to be honest about if people are going to live in communities, we have to pay in ways that make sense. I hear people talk a lot about ICFs and what a great system it is. Well, there's nothing magical about the ICF other than the payment structure. You get a daily rate, and that rate continues every day as long as that person lives there. So providers can budget to that rate as they're doing it. Makes life a lot easier to do that, and you can pay staff at a different level. We have to recognize that probably our regulations are so onerous on some providers, they don't measure the right things. So what we do is we have people responding to a lot of regulatory issues that really make not a lot of difference in what happens at the end user. So we need to change the focus of that. Not that you don't regulate providers and that you ask for high quality, but frankly, we've got to go after the things that make a difference in quality. We do that at a different level, we probably free up a bunch of money that we can pay staff to do things differently. And finally, I think the long-range plan is that if we start paying for outcomes, and real outcomes, and for people with IDD, the outcome isn't going to be people getting better. It's going to be about long-term supports and what that looks like in community. We have a chance to rethink the way the provider system responds. Now, I'm not bashing providers because I think they've been given a very difficult road to deal with. So we have to rethink those things. And of course, you know, there are other things we can do to address it. I'm a big believer in technology, especially for a lot of folks that may not be as high need as you're describing, but we can use smart home enabling technology to make a huge difference in the way that people are supported in communities. But we have rules and regulations that make it almost impossible for people to do that without fear of getting sued, because they don't transition people well to those. How does that help people with more intense needs? Well, if we're spending less because we're helping people become more independent and folks that maybe don't have as intensive needs, then it does leave a little bit extra money to people that are on the waiting list and for folks that have more intense needs. So there are some strategies we can do without new money, but we have to work fast to begin to change that. And I'm sure you have a bunch of other things that you're going to tell me, and I'll get an email soon on, right?
Thank you, Jenny. Okay, my question's a little bit different into the fact that I want to know when the state is going to hold the providers more accountable, number one, for what they're supposed to do. And when a rule is handed down and the provider realizes, oh my God, I'm gonna lose this big amount of money, so we go run into Raleigh. And you guys say, okay, we won't make you follow that rule. We'll put that rule out there for another 6 months. So you go back and play just like you were doing. And we won't take that away from you. So I wanna know when Raleigh is going to decide that the consumer is what's important and not the provider, and getting all their little money, and the first time something goes that isn't going the way they want it to, and they go running down there, you go, oh, no, we'll let you do that. We'll let you do it 6 months down the road. 6 months comes, now we'll put it 4 months down the road. Is that right, Jane? So now you tell me when Raleigh's gonna hold these providers a little bit more accountable, because I don't see it happening.
I tell you, I've only been on a job for 2
I don't care if you've been on the job 2 days.
I'm going to refer to a little bit of what I said just a minute ago. I don't think, there's certainly, I can think of the CABA thing and all that stuff where we didn't do such a good job at that, right? No, that's yeah, and I was well before my time, and I really didn't like talking about CABA then either. But the part of the difficulty in this, and this is a reason, not an excuse, right, is that we're trying to figure out, and I think it's legitimate, we're trying to figure out the role of the LME MCO in that versus the role of Raleigh. I'd say in Raleigh, that's pretty good, yeah. I believe that there is a role for the state in certainly setting standards and setting quality measures that make sense, that we all can agree on. And there's a role for the state to play in when things really go bad, that we have to be there, because ultimately it's the state's money. But we have to work with the LME MCO, and we have to do it in a different way, in more of a partnership, about how do we give them the tools that they feel comfortable being able to hold people accountable. Now, again, the conversation with Brian early, he's pretty good at this stuff and knows how to make that happen. But it's not as easy, because not only when they go to Raleigh, they don't necessarily come to me or to DMA. They go to the member of General Assembly while they're in Raleigh, and they call and they want to change things. So part of it is that we've got to set a trust factor that LME MCOs, state, and the General Assembly are on the same page about what our standards are and what we're going to live with. Right now, you won't be shocked to know that the General Assembly doesn't necessarily trust everybody over the department. They're not sure about how we're doing things. And as legislators, they like to legislate. And so there's that give and take. I think that we're on a way to create that kind of trust with them and with LME MCOs about those standards. No one in the department wants to see a bad provider continue to provide services. And I know no one at the LME MCO wants to do that. So we have to create something that is fair, equitable, and holds everybody to the same standard, so that we don't have these sort of arbitrary things that we've done in the past. The best I can tell you is that I hear you, and that it's on the agenda of how to work together to make that happen. And if you hear of it happening, call me. If you hear of it happening. How's that? Fair?
Yeah. Oh, yeah, your phone will be ringing. Dream.
I've got a more general question. You had referred
Thank goodness.
In your intro about the governor's partnership for a healthy North Carolina plan and moving to basically three big MCOs. Give me some selling points on how that configuration will help our consumers, specifically with SAMH and IDD issues. Sell us that plan. How will that help our consumers?
I think what I would sell it on is 2 or 3 points. Number one, and to say this, right now, in our carve-out plan, and that's what we have right now is a carve-out, essentially there is only one insurance company you can go to, and that's Western Highlands, now Smoky Western Highlands. So when people talk about a competitive process, there really isn't one, right? There's no competition. And for providers, frankly, if they're in Smoky's catchment area and they say run group homes, they really can't pick that group home up and go somewhere else. They're here. That's what they're going to do. The idea of 3 larger managed care organizations that all compete statewide is that you begin to compete on quality. Now, and I want to be clear when I'm saying this. This is nothing against any of the current LME, MCO leaders, and anything else. But the theory being is that if you compete on quality, then you sort of drive the train, right? If the LME MCO or the managed care organization or the CCE, I think is the word we're using, doesn't meet your needs, there's another one you can go to. And eventually, if enough people leave one, then they're no longer going to be in business. So they have an incredible incentive to make you happy, to provide the kind of service that you need. So that's one. The second issue that I really like, and I think the governor was real clear about this, is that up until about 2 years ago, in my job with the ARC, I would have thought it blasphemy to talk about integrating long-term supports that people with IDD need and physical health. But over a period of time, that changed in my view, and it changed because what I saw were the limitations of what we have in a carve-out. The limitations of this is that we treat people as silos, and that, in fact, I remember you, Jane, kind of beat me up on something about that not long ago, and it was, and it's really that there was no incentive for both parties to work together, really, because ultimately money drives how people work together, and so if the incentives are around how to move to make sure you have good outcomes for people, both health and long-term supports of behavioral health, then you create something that breaks down those silos for people, and that's, I think, the biggest seller on the integration. That I don't think anybody, in my opinion, today we all should be supporting integration on that. And then the third one, and there are several others, but I'll just stop there because we'll run out of time. Is I think long-term, the carve-out is not sustainable. It's not sustainable because you're talking about a smaller portion of the Medicaid money that eventually this system will require the General Assembly to put a lot more money into it if we're going to meet the needs of everybody that's out there. And I don't know that there's the kind of commitment's not the right word, if that we can count on that long term. I think they'll put money when they see that we do things well, but the big influx of money is going to be very difficult to get. You know, the economic times we're in. The best chance at saving money and redirecting it into services is if we're dealing with all of the Medicaid money, the 13 point somewhat billion versus the 2.5 billion that's a carve out here. And then just the last point, the 1115 waiver has the potential to offer a lot more flexibility in how we do things. The BC combo, I like to think about it in terms of, you know, it might be it's not a Ford Edsel or something like that, but it's really not a 2013 car, you know, if you think about it. It's probably a 2008, 2005, so you don't have all the bells and whistles on it that you could get in 1115. Now there's danger in that. There are some dangerous things about something that's that flexible, but if done well, it offers the opportunity to do a lot of things differently around payment reform, around how we integrate those healthcare and long-term supports and behavioral health.
This will be short, hopefully. What can you do, or what will you do to help Rutherford County with children under 18 years old with drug and alcohol problems to get inpatient care? We don't have anything in Rutherford County, and so they turn them out for outpatient care, and they just go back out to the
I wish I had a long answer that would tell you that I knew the answer right now.
I'll take a short one.
The short answer is that our system around supporting people who have substance abuse needs and people who need our assistance there is uneven. It grew up based upon, as you probably know all of this, grew up based upon who had the best idea in what county and what area. It doesn't have a comprehensive view of the state and how we do those. So it's going to take a lot of work to shift that kind of view so that we're talking about a comprehensive approach. The governor, this is one of those good news things, is that the governor sees dealing with addiction and alcoholism, addictions as a critical issue. And generally, of the things in our world that he mentioned in his inauguration speech, that was it. His wife has an interest in that. So there is a focus from the governor's office on how do we deal with these issues going forward. But there is no short answer, and there's no short-term solution. We have to rethink how we allocate those resources. Look at how do we create the kinds of how do we create a system that can be responsive quickly. And I think, as you describe it, we have to really focus on youth, because if we don't get to the young people, then we're just perpetuating the continued cycle. I wish I had a better answer, but I would look to some of your recommendations. I think that would be very helpful.
I'm actually going to piggyback on that just a little bit. Wednesday we came up with similar topics. I live in Brevard, it's a very small town, small market, but with a demand for high-end service, public service. With the inability of the consumers you get where that service is provided. And so we're left with that dilemma. I'm speaking specifically of psychiatric service, but others as well.
Well, I think, and I'm often afraid to talk about this because it sounds like it's the answer to everything. Here now, people click on the thing, but I think we have some really good opportunities around telepsychiatry and telemedicine in general around that, in particular outlying areas. And there's some really good stuff happening around the state, maybe happening there, I'm not sure. And there is a focus from the General Assembly on it. There's a project that they've pushed to add with UNC, not UNC, but ECU in Greenville, but that is to be statewide, which can build upon the things that we've been doing. Those kinds of ideas of how to get the right therapy, the right kind of docs, the right kind of medical attention in smaller communities using new technologies are probably our best hope to spread that. But I am reluctant to say it's the only answer because I know there've got to be more answers around how do you create a comprehensive service provider area in those counties that can use that. Sometimes it just comes down to how do you get scarce resources to smaller places, and it's really going to be a focused effort. It is an LME MCO dilemma in terms of the money they have to deal with that. But I think, again, I applaud Christina and Brian and Jenny for the things they're thinking about how to make that work. I think there's real opportunity to make a difference. And we have a significant role to play in making sure that, the funds that we have available get used in that way so they can target it to the right kinds of areas. But that's the best answer I have of it right now.
Hi, I'm Bill Cook. I'm from the small county of Mitchell, up in the mountains, and we currently have no intensive outpatient substance abuse treatment for the people that need it. What can we do to help get that needed service up in our county?
One of the things you can do is I keep saying it, and I say that sincerely because our system is uneven in terms of where things are available and how we've distributed those resources over the years. We have to hear from people about what's needed, and that's part of the reason why this is so important to get out and talk to people, because you don't get that sitting in Raleigh, and because people don't often get that opportunity to communicate. And then we have to have strong advocates who aren't going to back away and keep pushing me. So I'll say to you tonight that when I go back to Raleigh, first thing I'm going to do is ask our substance abuse experts about what are we doing in these more remote areas and how are we managing that. And I suspect what they're going to tell me is that we're doing the best we can with the amount of money we have, which isn't good enough. So we're going to push to look at things. But you should call me in 2 months and say, what have you done about it? Have you thought more about it? Have you forgotten it? Because as you know, other things will keep popping up. But the best way to do it is to make sure it stays on the radar. And so I want to count on Cfac and you to help us do that, all right, to keep that laser focus.
What's your phone number?
733-7011. 919-733-7011. And I'll leave cards here before I go, so you'll have that. Okay.
And we'll remind you in 2 months, Bill.
Yeah.
We'll have to.
She knows me.
I do.
Thank you.
You've answered my question, so I'm going to pass so that there's a lot of time for guest questions.
Well, this has been, I'm quite overwhelmed because there's a whole lot that needs to, I can't, I'm looking very forward to sitting across from you a year from now and you telling us what actually has happened, because because we haven't seen a lot in a lot of years, and I hope this talk really, I hope there's some legs to this, to these things. You know, it's a great idea. My focus is in mental health, and continuing on with talking about the crisis facilities needed. Along with that, what dwindling services are still available for mental health is for the individual who recognizes they need help. The huge crisis for parents and for the individuals are the ones that don't recognize, are not in a state of cognition to understand they need help. This is, and the services need to tie, the crisis facilities need to tie in with change laws, quite frankly, with mental health courts. Is there anything like that that is being considered as a part of a whole?
Well, I'm glad you asked that, because in my effort not to give you the stump speech, right, we're still off it. Part of the stump speech is this, and I'd say it sincerely, is that dealing with the crisis around mental health and substance abuse, and frankly IDD, doesn't stop at the walls within DHHS. Say in the Albemarle building, it doesn't stop at the walls in Smoky in Western Highlands. Community partners, the people that are outside our system, are just as important as we go forward. So as you talk about this, you know, law enforcement is critical in terms of how we address issues and how we manage that. The CIT programs are really an amazing development in terms of how that can change lives in doing this. Our school systems, you know, we have to have a much different relationship with DPI than we've had in the past, because that we know that for a lot of folks, we identify issues in high school and sometimes even before that, and so we have to have a relationship with them that's different, and we have to reach out to other sort of non-traditional community partners. I mentioned the faith community because I think it's important that we do that, but there are lots of other places that we have to engage in terms of really reaching out. So I see my job right now is to listen and to come back and try to get our house in order to make sure we're doing the right things. But frankly, the long-term role is that we've got to reach out across those boundaries to engage other people in these efforts to be a part of the solution. And that includes looking at all of our legislative actions and all of our legislation around that is substantive legislation about mental health, and frankly in IDD and everywhere across the board. Because what happens, as you know, is that one day a constituent will show up to a legislator and they'll have a great idea, and they'll write a law. That law may or may not help the system, depending on whether it really was a great idea or not. But it isn't part of a larger view about what we're trying to achieve, because all of these things work together. So I'm not. I don't want to overpromise, because that would be wrong. But on the agenda, and it's probably not in the first 6 months, but it is as we get ready to look at the next long session, which will be January 2015, right? Yeah. I got to do the math, but yeah, 2 years from now, we'll do is to look at the entire mental health law and the spectrum around that, because we have to look at those issues. The reason why not in a short session is because they won't take those up, but we have to begin that process. But it is, all I have to say is much bigger than what happens in DHHS, what happens at Smoky, what happens actually in the Medicaid program. It's a larger issue that we have to recognize and engage people from across the community about. So thanks for bringing that up. That's really critical.
Before we go back around and ask any more questions from Cfac, I know there's a couple sitting over here that Janet probably has some questions. Jerry might. So I'm going to give you guys over here an opportunity to ask one question, and then we'll come back to Cfac. Janet? Yeah.
Okay, I'm trying to figure out how to get as many questions into one big sentence.
Always one of you out there.
Yeah, there is. The changes that you're suggesting, what we have now is managed care. What you're proposing is also managed care. And managed care is all about saving the dollars. 1115B waiver, again, managed care. No other state is doing, every other state that's doing 1115 is carving out DD. They're leaving MA and SA in, but they're carving out DD. So how are you gonna make sure that, you get what you need if you're just about saving money with a bigger insurance company? And if it's just about getting the right services to the right people, who's gonna decide what the right services are?
It's like 5 questions, come on. Those are absolutely great concerns, and they're things that you should be concerned about. People are carving out IDD right now, but they won't carve them out long term. They'll come back in. I don't think that's the long-term path that people are going to be on. Again, 2 years ago, well, hell,
Yes.
2 years ago, I was fighting the whole idea of this managed care waiver. So the.
That was one of my original questions.
Right. Well, there's no secret about that. You know, there's a record right down there.
Yeah, it's an email.
The train has passed. You know, we're there. We're not going to go back from a managed system at this point. The question is, what's the best managed system that you can have? I think something should be encouraging about what the governor has said and what the secretary has said, is that there is no preconceived notion about how much money would be saved in this new system. In fact, the governor's budget and with the request of the General Assembly added another $550 million to the Medicaid program over this year alone. And now part of that's because we had cost overruns, right? So you had to fund it. But there isn't this sense of we're going to put that money in and we're going to pull it back by a managed system. What the governor's proposed is that what's in the Medicaid program stays in the Medicaid program. There isn't a preconceived notion of how much money gets saved. One of the things I would argue that was wrong with the BC combo as we started, and we are wrong, but I think may have been a little bit disingenuous, was that the savings was in the front end. Is that the capitation rate took money away from what was already being spent, which frankly was a bad deal for the LME MCOs, but they had no choice to go because you have to go, right? So that's what you guys know that better than anybody, I think, in this community. So the good news is that wherever we're headed, there hasn't been this preconceived assumption that there'll be a savings to begin with. There is a preconceived assumption that we'll get cost predictability and that we're not going to have these large cost overruns going forward. In terms of who determines widow's right level, what I would be saying if I were you is that you demand that who determines that, or the Cfacs and the other consumer and advocacy organizations have to be at the table as those things are debated and understood. And we're not running out of time, but the secretary and Carol Steckel with Medicaid started this office hour idea. I don't know if you've seen it, but where people call in and show up and discuss what they're thinking about. They get an hour in there. Well, since I've been on, I've been in all of the ones around behavioral health and long-term supports. It's not a show. It's real. It's about people showing up and talking about what those ideas are, what makes a difference in their lives, what makes a difference as a provider, as somebody that runs an organization, a therapist. But I think most meaningful conversations have been from families and people with disabilities showing up. The things that have moved Carol the most, I know, in terms of her conversations. I tell a story. I was at one of them, it was the week of July 4th. I think it was on the Friday afterward or Wednesday before. And this one man came. And he came, I think he was a member of Cfac somewhere, and what he said was that, I don't know if you're going to listen to a thing I say, but I could not, it's not the way to say it, but I could not come. I felt that no matter what you do with it, I had to tell you. And he came in with 3 ideas that I suspect that at least one of them is going to wind up in whatever the ultimate system looks like. So the point of that being is that the only way we're going to get this right is that if it's an active engagement with families, people with disabilities, providers, LME MCOs, therapists, professionals, to determine what that looks like. And that's the commitment that the secretary has, it's the commitment I have, it's the one that Carol has at Medicaid, is that this is not going to be us going in the back room and figuring out something, but rather something that takes into all of these considerations. The best I got. Good, that's right. That's what I'm going to do.
All right, I think I saw one lady over there.
I want to kind of make a comment and then go from there and give you a little bit of history of why I'm saying what I'm saying. I'm a parent of a child with special needs. We started off in the mental health reform years ago with the system of care and the child and family team approach. that has been the most, that helped him get where he's at today. He lives in an apartment with support, but he is in the community and not in an institution. And it took that team of folks that stayed engaged and wanted to see the outcome for Dakota. They invested. They invested their soul, their hearts into our family. What I'm seeing now as I'm working in the field with families is we say we're doing system of care. We say we're doing child and family teams. We can dot our I's and cross our T's, but we're not keeping to the fidelity of what system of care was supposed to look like in our communities. I think, you know, the providers have to go and get trained now in system of care and child and family teams. Parents are not understanding that it's even a child and family team that they're attending, and then community partners are not at the table. They just are not attending the child and family teams. What I seen was DSS decided they'd do a child and family team, and their system of care approach. The school decided to develop their own. And in the beginning, what the division told us was it'd be one child, one team, one plan. I think we're moving there. It seems like that's what I continue to hear from you, is that as a system, you're going to start to collaborate with one another and collaborate with the partners within your communities. So I'm looking forward to seeing what's going to happen here, and I see that theme at your level of what you're saying, and I just wanted to really say that it works. Our family's living proof that it does work if there's a way to continue to push that education.
That's very helpful to hear. I heard the social services part about that, and one of the things that the Secretary has drilled into our heads as division directors is that we have to collaborate in a very different way, and that this is we're a department. We're not 11 separate divisions, however many of they are. And that sounds like a great place to start the conversation with my counterpart at Social Services about what's happening.
And we have the collaboratives within our communities.
That's hard to say.
Yeah. So we, especially here in Buncombe County, it's just been amazing to see that it's continuing to grow. People are continuing to come and try to figure out ways to support the children with special needs within our communities. And Western Highlands really had come in and started building those relationships within all the counties. So that collaboration is going to be the key in building that trust with your community partners.
Yeah, and I know that there's a lot of great work that's happened here, and I can't imagine that Christina is not like a cheerleader around system care, because that sounds just like her. So I think you've got a real strong advocate that's coming in there also to keep that going.
Thank you.
Thank you, Madam
You were
Chair.
just taking pictures. Now wait a second.
Yeah, you got to be careful how you talk to me.
Sorry.
Thank you, Ms. Richards, for coming. I've spent about 25 years of my life advocating for kids with special needs in the 7 western counties. And one of my big beefs about all the other agencies, the school is one big elephant, but all the others just comes in and sits at the table, but they're really not participants because they really are not supposed to be in the way the structure is under IDEA law. So when you go back to DPI, you're going to find out that the Disabilities with Education Act is really in conflict with what you're doing, because DPI has the responsibility to do the things that is supposed to be done, but they're not doing them. They're pulling in the mental health, they're pulling in DD, they're pulling in everybody else to come in to do what they're supposed to do and trained to do. Now, doctor shortages, you're going to see that's the big problem. It's a good concept to talk about integrated care, but you don't have the structure to do integrated care because the doctors are leaving because of Obamacare, if you want to know about it. Then you've got the schools, you've got the retirees leaving with a big paycheck for all the years of services, but the same principle behind what you're doing here in the mental health reform that I've watched even from Carmen Odom. It's coming right down to exactly what she said right over here at Mayheck Center. She drawed the map, and it's being done, right down to the T. And my concern is that the kids are not getting the services they need because the older teachers are retiring, new teachers are coming in, and they don't have the training, and then they're wanting to pull in your agency for all kinds of advice and help. So when you talk about integrated care, how can you have the integrated model if you don't have the law supporting the education piece along with the agency or divisions piece, because you're in conflict right now? So I'm making a big picture, but really the big picture is where it's at, because DPI, they've never really done their job. That's period. They've never done their job. And I think what the lady is talking about over here, how the children doing these family team meetings, under IDEA, it's structured to get this kid early and fix them early. Don't wait to high school. So I think that piece is lacking. Now, the piece at the hospital, I think it's lacking because we've had plenty of kids ending up over there. And the doctors treat them, get them stabilized, and didn't have nothing to take them to in the community because support wasn't there. But it was being paid for, but it wasn't being billed. So how's that monitoring piece going to go? So I'll give you a whole lot to take back with you.
That was more questions than you asked, really.
Well, Janet told me to say all
That was good. I don't know if I don't think there's an answer that I can give you other than there's always been an historic and I think legally, you're right, legal issue around how school systems and mental health agencies work together. And I am not naive to believe that gets broken down overnight or frankly over a long period of time. But if we don't try, if there's not a sincere effort to work with, where I could work with is at the DPI level to try to at least begin to understand our systems and how they work together and how they should work together, then I shouldn't be doing this job if I don't take a shot at it. So all I can say is I'm going to take a sincere shot at it, and hopefully we can begin to see some changes over time. And that's I think you said our way in. That's the best you can do, right? Is give it your best shot. That's the intention.
Thank you. Okay, I'm going to come back. We've probably got about 5 or 10 more minutes. I'm going to go back around. I know some of you have some follow-up questions. Leslie, do you have anything?
Not really. I think Ron covered that pretty well. I'm from a small county that has practically no services. We tried an integrated, it's Polk County. We had an integrated model. I'm not sure it's working that well. And we have another provider that provides limited services. But none of it meshes together, none of it works well together. Any mobile crisis unit has to come from out of the county. Any ACT team, by the way, somebody mentioned that system of care is not using fidelity to the model, neither are the ACT teams. And I've seen evidence in a couple of counties, including, well, it wouldn't include my own because we don't have it in the first place, but in a neighboring county, that providers are keeping clients in their patient load who should be referred to a provider with an ACT team, no matter how poorly that ACT team is. At least the client is, I hate the word consumer, by the way, at least the client is getting a little more attention than a 3-month psychiatric visit. So there's a lot of that stuff going on. And it's not helping the clients at all. So you have to watch that when you go to competition. And I am a free market person. I do understand that competition is important, but sometimes it boomerangs. And we don't have anything in Polk County. Telemedicine might relieve some of it, but I think you need to pay a good quality provider a premium for coming into a small county.
So you are, Brian is singing your song.
I've been singing that song for several years.
No, I'm serious. Like just as we met before and we were discussing some of the again, trying to learn what's working and not working around there. That's exactly as he described the system that needs to work.
Yeah, I mean, we have people who really, well, you know the story. But that's it. We just don't have the services we need, and what we do have are at least thin. And most people land up in the emergency room and stay there for a while, like weeks sometimes.
It's a simple question, again, dealing with the judicial system. What is the role of the division in the development and expansion of mental health courts?
I think our role is to bring to the attention of the General Assembly those things that are most promising practices across the state that work. And so making sure we have the right evidence that we can bring to them to show those things that work in a comprehensive system that's going to make a difference. Again, that's talking, our responsibility can't just be about this managed care waiver and the, again, the walls of the HHS. It has to go broaden that. So that's what I see.
Well,
You could have stopped.
Christina's laughing. I'm going to say, I think it's pretty well been summed up around the table. I mean, we're talking Polk, Rutherford, Transylvania, Mitchell. We're talking about inadequate providers. We're talking about providers going to Raleigh, not getting. I'm a real strong advocate and have been for over 2 decades. I sat at meeting after meeting after meeting. I've spoken at the Legislative Study Commission. I've written letters, as you well know. I've advocated the best that I know to advocate. People are scared, people are tired, people have given up hope, and we have a new administration, we have new people in the offices in Raleigh, and I know it's just beginning, but I hope you're hearing all of these counties that don't have services or have inadequate services. I hope you hear of providers that get what they want, but individuals aren't getting what they need. I hope you hear that there are very high needs individuals whose needs are not being met, which means that is an unidentified need. How long does the state have to say, this is a need, it's been identified? All these counties, all these individuals that are on this committee can go with unmet needs. For how long? I'm 22 years now. And something's got to somehow change, because I am even more discouraged sitting here today listening to what's going on than I was before I came. And I don't know how else to put it. It's I hope you can go back to Raleigh and let them know that we don't have adequate providers, that we don't have adequate services for individuals, that individuals' needs are not being met, and this is not new. This, for me, is over 22 years old. So I don't have a lot of confidence right now that I expect to see a lot of changes. So convince me I'm going to see the changes.
I think, could I?
Please, Brian, jump in now. Yes. Where have you been?
I'm sorry.
I appreciate all your comments. I don't want to take a lot of your time because it's really about you folks being able to ask Dave questions, and he's been a real gentleman in, I think, taking responsibility for a lot of things that aren't completely his responsibility, to be
Well, I
honest.
think we all realize that.
Okay. And I don't mean to say you're wrong in what you're saying, but I think I need to stand up and tell you that Smokey, you know, the new consolidated entity has responsibility, probably the majority of the responsibility for all these things you're talking to him about. And that's just the way it is. Is there ever going to be enough money? No, there isn't. And we're going to accept that. The challenge is to take the money that we have and get the best possible treatment, value, and outcomes for consumers. I talk to folks about this all the time. That is what our job is, okay? And we would love it. If you can give us more money, we would just love you to death, okay? But what we have to do is be willing to make the changes necessary to get the greatest value and the greatest access to care. So a lot of this that you're talking about, and I appreciate Dave's response, and really, those are the questions I need to be answering for you. Now I'll sit down and let you answer.
So that's great. So from now on, we're sending you to Brian. That's really good. And Brian's absolutely right. What I can say to you, why should you feel different, is this, is that I am convinced that I'm convinced by action and I'm convinced by word that this administration, the secretary, will not tolerate indifference to making these things work. So our system now is one in which the LME MCO has the responsibility for doing these things. He's not going to have enough money to do it all, right? But if the LME MCO doesn't, our responsibility is to hold them accountable. Our ability to do that is by contract. I was telling Brian, and I told LME MCO directors this, is that, you know, we can write a better contract that can hold people more accountable when we do those things. And we will, and we'll negotiate that out, and I think LME MCOs will actually like that. It's a better contract. But that isn't how we're going to address the most critical issues around the state. The way we're going to do it is the one-on-one conversations with LME MCOs, hearing this kind of conversation, that we're all in the same room together to recognize what those issues are. That the LME MCO does its job in managing that network of providers, holding them accountable. We do our job of trying to figure out the right mix of resources and holding LME MCOs accountable, and going beyond the walls of what this can do in terms of developing those relationships, and continually sort of doing the feedback loop. If and I'll say this to you, if the only time you see me at this Cfac meeting or whatever it looks like is today, over however long I have in this job, then I haven't done my job. That's we have to listen. And the only way we can find out what's going on the ground is to be out in the community and figure that out. It is not going to be perfect, and it's not going to happen overnight. But again, I'll tell you this, is that I don't think I will have an opportunity to be in a job very long if we don't begin to see progress on the most critical issues, because Secretary Bosch is not a patient woman, and she's real clear on every day about what are you doing to make a difference. And I frankly think that's terribly refreshing. And it is the right way for the leader of this department to act, and we'll get it done. We're going to get things done, not everything overnight, but things will change, and we'll work with the partners that we work with in the community to make that happen. I was very pleased, and so no secret that Brian and I argued a little bit before in my old job, right, about where things. Christina and I argued about things. But I feel I don't think there's any inconsistency with what he and Christina believe about how we're going forward, and Jenny and the rest of their team about how we're going forward, and what the secretary is looking for and what I'm looking for in terms of a system that works. We'll disagree at some point in certain things, but I think together, working as a team and people believing and trusting one another, we can make progress. You've got to be part of that solution. And that's really the message, is that what you've said today, the questions were really great, they're very helpful to engage, but honestly, we need, as much as questions, we need answers from you, you know? You said a lot of them. What are those things? Send the emails, make the phone calls, keep engaged with these guys and with us, so that we're all working together to try to achieve something.
Well, for me, I'm just gonna kind of piggyback on what most everybody said in here. When I have an IDD son that lives in a county, that for me as a parent, there's not one provider down there that's gonna provide services for my child, because number one is I don't trust them, number two, they don't do a good job, and number three, they're not held accountable. So he doesn't get any services in Rutherford County, other than the fact is I've heard from day one is we're gonna have choice. We're gonna be able to choose. Well, guess what? I don't have choice. I can't choose. There's one provider. If I don't like it, tough. So, and if I cause a big enough stink, they can send me a letter and tell me I gotta get my son out. So I don't have a choice. I'm stuck unless I take him out of the county that he lives in, his friends, his home, his family, which is not fair to Jerry. So, am I happy with Rutherford County? As my French goes, hell no. Will I be happy tomorrow? No. I don't know where the change is going to be, and I don't see a lot of it happening. Rutherford County's been that way. It's going to probably stay that way. So for me, I think the state has a lot to do to hold these providers accountable for what they do and to get more choice in there to make sure that our family members get what they need and are given the services that these providers are getting paid for, that they're not providing. So that wasn't a question. That's just, you can take it back to Raleigh for me.
Question, comment. I was going to comment on increasing, there is a need for increased intensive residential services, especially for children. Case in point, consumer I represent,